Welcome to Zen Footsteps. My podcast is designed to invite you to explore new perspectives and challenge the way you see the world. Through engaging conversations with thought-provoking guests, we're going to delve into the idea that you can transform your thinking and inspire personal growth. From redefining success to uncovering unconventional paths to fulfillment, each episode is a step towards expanding your mind and embracing the journey of discovery. So join us as we walk alongside innovators, thinkers, and change makers who can help you see life in a whole new light. Jag, hi. Great to have you on Zen Footsteps. Thank you for joining me. Looking at your bio, listening to your bio, as everybody's just heard, it's quite something. And if I could, I would like to sort of kind of go back to your childhood a bit. Did you kind of always want to be a surgeon? Was this something that you were kind of born to?
Yeah, I still don't know what I want to do when I grow up, actually. That kind of summarizes the journey. I wouldn't say a surgeon. I just wanted to help people when I was a youngster. First generation migrant with parents that barely spoke English and didn't go to school in their home countries before they migrated. During the big migration in the 70s in the UK, when there was a big labour force push. And so they came to the UK. It was quite a kind of romantic story. My father was the youngest of three sons, and so I'm setting the tone of the story, fairy tale story, and he was the favourite and selected to come across to the UK with my grandfather, and they started a new life. They had a very strong work ethic. Worked in factories. My father worked 7 days a week in those early years, and so they provided for us as much as they could do. And I wasn't really in a kind of an environment in which kind of high academic achievement was encouraged. You know, it was a very traditional family, and the aspirations and ambitions were, local, community based. But I started to feel like I needed to just go out there and see the big wide world and not be too constrained by those restrictions. And then the penny drop moment with academia, and actually, if you don't educate yourself, you're not, the opportunities are limited, and maybe I'll be working in a factory. I think my father sent me to a sweatshop when I was 15, 16 that summer holiday, and I worked 7 days a week like him. And that was in the West Midlands, and it was tough, 13 hours a day. And he turned around to me and said, well, if you don't educate yourself, and I may not be able to provide you with that education, but this is probably what you're going to end up doing. So you need to think about where you want to prioritize your time. And that then led on to thinking about working in a healthcare setting. I don't know if it's in my bio, but I actually started as a qualified nurse. I did that first. I always wanted to be a dentist. Because that's a very, what I love about dentistry is that it's a very practical, hands-on position. But you finish your 5 years, and then you're fairly pretty much like chiropractic and most of these professions. You're an independent practitioner when you finish that basic 5 year period of training. So you have complete autonomy, and that was quite attractive. But then took some time out to get that extra research degree in pathology, and then fell in love with academia. So that's how I then ended up going on to do medicine, to become a maxillofacial surgeon. In the UK, you need dual qualification, but it still wasn't enough for me. And then it ended up with that PhD.
Was there any particular person that inspired you? Like I know that when I was training, there was I had migraines. I got treated for migraines, and they went, and I was so impressed, and it so inspired me. Was there anybody that you can think
Yeah,
of?
I had an uncle who was a dentist. That was an inspiration to think about dentistry. And this was at a time when it's not like today where you had to have straight A's and be massively performing and competing against a very, very clever bunch of kids. So I got into nursing. I did my A levels in the evening. I got through and into the University of Bristol. And that inspiration for dentistry was certainly that early childhood experience of one of my relatives who was doing dentistry.
And what were the biggest challenges you came across? Because I know that when I was living in nursing quarters while studying to be a chiropractor, and it was hard. It was hard, general surgical ward, 10-hour shifts, and then Was it the same for you? Did you have to kind of fund yourself? How did you do that?
Yep. So this is well, I'm old enough to be part of the grant generation. We got a small grant. Our fees were paid, so there wasn't a student loan. And I once I qualified as a nurse, the income from a locum nurse in intensive care was very reasonable, but that would mean evenings and weekends spent doing that. And I realized quite early on in my academic journey that it would take me as long as it took me to get the results I needed. And what I didn't want to do was to struggle about or worry about whether I was just a pass fail, but I needed to worry about whether I came top of the year or not. That's a much more comfortable position to be, because you know that if you don't get that grade, you're still going to be okay and get through. And so that work ethic of working 8 to 10 hours every day was manifest in my undergraduate curriculum, such that I was successful in getting funding for that intercalating degree in pathology in the top three of the year. But the weekends and holidays and night shifts were filled with extra work to fund those years of training.
Because I mean, I mean, I think your dad taking you to the sweatshop was probably a really smart move, because
Mm.
it's same with my kids. It's like, yes, I want you to be happy, but just so you know, this is what it's going to be like if you.
Yeah, I'm not allowed to say these words anymore, because obviously I've nagged my children to death about it. But if I was asked, apart from the obvious things, you want your children to be polite, you want them to know right from wrong, you want them to be courteous, respectful. Uh, but also, if I had to put it into a couple of phrases, it's ambitious, but also to have insight, because you will know what you need to do to get to where you want to get to. That's your insight. And if you're really ambitious, you'll push yourself and push yourself as much as you can.
Yeah, I totally agree. So for a lot of people listening, they don't have the kind of medical background that you and I have, and the understanding of anatomy. If we could break down sort of head and neck and surgery, and could you break it down in a way that they can understand exactly what it involves?
Yeah, so I guess further on to that journey after the PhD, what I ended up doing was my full surgical training with dual qualification, and then took some time out to get a degree in oncology, PhD. My PhD is oncogenomics and transcriptomics. And so I had an interest in head and neck malignancy. Now, what's wonderful about head and neck anatomy is three-dimensionally it's quite complex. And being a reconstructive head and neck surgeon means that you need to appreciate the subtleties of that three-dimensional perspective, particularly when you're putting everything back together. So I do a couple of surgeries where I'll take out the fibula bone and I'll use that to rebuild a jaw. I'll take out thigh components of the skin, and I'll take out the vastus, the muscle that sits in the front of the thigh. And I can dissect the various blood vessels of these components to be able to pull it all apart and then put it all back together in the jigsaw that is head and neck reconstruction. And the reason why that's quite a complex kind of process is that, unlike reconstruction anywhere else in the body, we have to manage saliva. So oral cavity malignancy, for example, you can take out even a T1 tumor. This is the classification system we use for cancers. T1 means it's less than 2 centimeters. And as a surgeon, you look at cancer, you feel it, and you take a guesstimate, a judgment call as to what margin you need to get it all out. And that is the most important thing you need to do, is get cancer out. But if you imagine a 2 centimeter cancer means you have a 4 centimeter hole. Now, in the mouth and on the face, that's quite significant, particularly when we have saliva. So to be able to manage that means you have to immediately reconstruct head and neck malignancies. Otherwise, you have saliva leaking to the neck, patients can't talk, they're functionally do really badly. And the modality in the treatment for head and neck malignancy is surgery first rather than radiotherapy. So taking apart somebody's thigh with those various components, we call it perforated dissection, chimeric free fat reconstruction, and then putting it all back together with, have I taken any of the inside lining of the mouth away? Have I taken any of the skin of the neck away? Have I taken any bone away? It allows you to adopt what's called a personalized approach in reconstruction, in putting that all back together so your patients get the best possible outcome. You're only going to get that kind of complexity of three-dimensional anatomical perspectives in head and neck.
And in terms of doing that, in terms of like major things like carotid and things like that, I mean that's got to be incredibly complicated, and I mean the risk involved for something like that, and also brain supply, circle of Willis. I mean it's not like another organ where you've got just a kidney and you know it. I mean that's surely the complexity, and one could say the risk factor in that.
Yeah, I mean, the stakes are always high with any kind of surgery. I'd never underestimate it. I mean, even having done a lot of dent, you wouldn't think it, but I would say that taking out a wisdom tooth can be just as complex as some of the most complex surgery. The stakes are very different, obviously, and the training pathways are different as well. But in my surgery, in my type of surgery, everything is actually the opposite. It's very predictable. The outcomes are very focused. 4% of flaps will fail, 96% of flaps will survive. And this, when I talk about a flap, it's when you detach one part of anatomy, the radial forearm free flap, the thigh, bone from the fibula or the hip, and then reconnect it to the blood supply and vessels in the neck. The process and the it is so well thought out. The training has to be so robust that the outcomes have to be as high as 96%, if not more. I'm quite fortunate in that I'm a little bit better than that. And so it's understanding the limitations of anatomy. The most challenging part of anatomy is when we're operating into post-radiotherapy fields. That really poses a problem in terms of the way that you handle tissue. Surgeons are, ironically, really adverse to the sight of blood. We don't like the sight of blood. And when we operate through planes and tissues that are bloodless. And so what that means that you can do is have a very controlled process in getting through a surgical procedure. Now, where that differs is in the removal of cancer, because unlike going through planes that are bloodless, you have to follow the planes of the cancer. And that means you'll cross these bloodless fields into very bloody fields when you remove cancer. But again, there are very safe methods in place to be able to remove cancer safely without compromising patients. And that's probably the most important thing of being a head and neck surgeon. If you don't get the cancer out with a good margin, you're committing them to radiotherapy and all the additional impact that can have, the morbidity associated. So you need to make sure that you prioritize cancer out rather than rebuilding. But of course, your rebuilding, your reconstructive techniques need to be the full repertoire so that you're not limited in your ability to put somebody back together.
And is that, I mean, are they doing cauterization or more laser dissection now, or is that still just pure
So
dissection?
So it depends on where the cancer is. So, for example, in oropharynx, we are using robots to remove cancers at the back of the throat. But oropharynx is HPV, a virus associated, and the primary modality for pharynx and larynx is actually radiotherapy. So, in those kinds of conditions, you're using laser ablation, minimal access if you can, with debulking. But the common and modern modalities of radiotherapy and chemotherapy have got wonderful survival rates. So in pharynx and larynx, you would routinely debulk if necessary, but use radiotherapy and chemotherapy to manage the cancer. In oral cavity and face, however, you have to use surgery. And so it's a wide excision with a cutting instrument of sorts, but just to kind of add a little bit of a potential future application. One of my PhD students at the moment has been exploring the use of a cutting instrument in which the instrument sucks up the smoke from the cutting instrument, analyzes in real time whether you're cutting into tumor as you're doing it, and imagine combining that with a robot to create a chemically aware robot. So that's all the technology that's on the horizon.
Well, that's incredible. I know that they've been using dogs as well that can smell cancer and detect cancer. And I've always thought, well, that's just about scent. And if we could analyze that scent and computerize that scent,
Mm.
we'd be able to, discuss, well, find cancer way before it happens.
Mm.
So in terms of something I've seen on the rise, I want to know your take on this, which is esophageal cancer. I seem to be again and again, I'm coming across this more and more. Do you think there's a reason for this? Do you think it's a lifestyle, or what's going on there?
I mean, I'd say possibly. We know that nitrosamines, maybe even vaping, for example, these are unknowns. Are they contributory factors? Uh, the um, the effects of H. pylori and gastric acid disease has been managed wonderfully by by modern medication. Just the simple protein pump inhibitor has helped to reduce that, and therefore regurgitation has diminished significantly, and then that irritation that you get in the esophagus. The problem with all of these deep cavity structures is that often they symptomatically present quite late. And so it may well be and usually is a lifestyle related issue rather than a hereditary factor. But if you're to pinpoint the specific cause, I think that probably will be quite difficult.
Okay, because I know that there was they had two twins that lived in the Orkney Islands, and one twin left and one twin stayed. And the one twin that left and came into cities and that, they compared them a year later, and his face was sunken in, his whole kind of oral cavity and all of that in terms of health wasn't great. And you looked at the other twin who stayed in Orkney, who had a good diet, fresh air, and his face was robust and round and everything. And I see this more and more, like you and I both spent time in Africa, and I know in Africa too, there are certain things that I see more and more. And then in the West, I see almost like a modern disease. Like, for example, in Japan, they're now starting to get what I call Western diseases, because they used to have a lot of foods that were fermented foods, and they used to have a lot of seaweed. And a lot of the women over there weren't getting sort of the classical menopausal symptoms. And I think for me personally, I've seen diet plays a major, major role in this. And I worry about vaping because we seem to have got rid of smoking, but now we've replaced it with something else.
I think it's been quite interesting traveling to Africa. Over the last year, I've traveled to 9 African countries as I kind of broaden the potential of using some of the technology that I've been developing for training surgeons. It's quite interesting seeing how opportunities for training and the health provision changes subtly between African countries, but then very dramatically when you go from somewhere like Burundi to Cape Town in South Africa. And that's partly related to the environment, but also absolute poverty as well, the provision of healthcare and healthcare services. There's a political background to all of this, and a commercial narrative behind that. But there's one commonality, the commonality of surgical approach, the commonality of human anatomy. There are some subtle differences. The African abdominal wall, for example, is quite different from a Western abdominal wall. And the reason for that is because their diet is very different to the Western, highly refined, high sugar, high fat diets. And so you see those subtle differences, and that's all purely environmental rather than genetic.
Yeah, it makes sense. We see a lot of, my wife works a lot with leaky gut syndrome, micro tears in the gut. We're seeing a lot of diverticulitis in the West, and in Africa, again, I see less of that. So you mentioned there in terms of technology. Can we kind of move on to that? And we talk, because it's very exciting. One of the reasons I wanted to have you on the show was I'm a bit of a geek when it comes to technology, and I was just super excited. It was like meeting a spaceman when you're into your rockets. Tell me a little bit about how it all developed in terms of, we can talk about the app as well, but how it all developed in this augmented reality.
So I'm the CEO and founder of Virtual Reality Medicine and Surgery. There's two camps as to how you would pronounce that acronym. There's the VRIMS camp, and then there's the VRIMS camp, and I'm sitting in the middle. I don't think there's any right or wrong. This all came about when COVID happened. Being a very keen educator, an enthusiastic educator, in my hospital at East Grinstead, Mackindale pioneered surgery, reconstructive surgery in the Second World War with the Guinea Pig Club. And there's a huge heritage there, and we use a phrase that we train our trainees to be trainers of surgeons, and that's a slightly different kind of a mindset and approach to how you train. Having run several cadaveric courses, and then the pandemic happened, I needed to start to think about how I could develop alternative techniques. I mean, of course, then webinars, Zoom, Team, all really took off, and there was widespread adoption. But I wanted something that was more than just a conventional webinar. And having played around with VR technology, virtual reality technology, I started to look at how I could explore that technology at a much bigger scale than it had been adopted previously. And so I'm just going to clarify some of the terminology here. So extended reality is the overarching terminology that we use that encompasses virtual reality, augmented reality, and mixed reality. And so in virtual reality, you're either going to create a digital environment in which you can manipulate objects and they behave and have physical characters like the real world. They call that 6 degrees of freedom. But you can have additional immersive experiences in which you just use a camera with a lens at the front and the back. And so when you put the headset on, uh, you're transported into this new world, which is not the real world. In mixed reality, there's a little bit more of an interaction with your surroundings, and we're seeing these devices that are coming through. And in augmented reality, you have the real world on which you will augment an image or add something to it, usually with a screen or a mobile phone. And so playing about with a variety of technical aspects and cameras and virtual reality, I decided to do something that had never been done before during COVID. I decided to live stream a surgeon performing procedures on human tissue. And the reason why that's never been performed, because there's a huge regulatory framework in which we can access. And normally you go into a human anatomy lab, as you probably will remember, you're not allowed to take cameras. You even touch your phone, you're out the door. And so when you make that widely accessible to the public, it becomes a public display, and there's regulatory frameworks with the Human Tissue Act in the UK to manage that, to make sure that doesn't happen unless there's specific permissions. And that's all part of being respectful to the donors, be mindful of this precious resource that we're given, where surgeons in high-income countries have access to these sorts of resources. And they are ultra realistic simulations, performing surgery on a cadaver and handling the tissue. The haptics or feel of tissue manipulation is about as close as you get to actually performing surgery. But of course, the stakes are slightly different, and there isn't that pressure to get it right. And we're not inconvenienced by blood, which we hate the sight of. So then I started to think about how I could perform procedures on cadavers using some of these immersive cameras. There were limitations to using a single 360 camera, because the problem is you can't move the camera when you watch that feed on a VR headset. So I developed something called a virtual studio overlay, where I can overlay multiple camera perspectives in a headset, and that gets around the problem of not being able to move the camera, because I don't know whether you've been in a theatre environment, but nobody ever stands still. Everybody's looking around to see the best view. So not looking around to see the best view was overcome with a 360 camera with multiple overlays. But cadavers allowed me to be able to perform surgeries at a fraction of the time, but ultra realistic in terms of sequencing through operations and the maneuvers that would be required. So I live streamed that first course to 100 ENT plastics and OMFS trainees, where I sent out these low-cost headsets on cardboards, and the mobile phone was the immersive device. And it had a huge response. And when we were able to live stream this to countries abroad, we ended up streaming to more than 100 countries and 6,000 participants in 6 one-week courses. And that's when we really got a sense that we were onto something that had real value for surgical training.
And can you, in the same way that a pilot would go into a sim, or maybe this could be something you're going to do in the future, but can you simulate, doing dissection or something, and suddenly you have an artery that blows, and it's less dangerous? Can you do that to suddenly to test them? Because ultimately, it's great when you're doing virtual, but in the theatre what it's like. You go to close up, you think it's okay, and you go, hopefully we've not left a swab in there.
There's another kind of fallback or criticism of the potential of this technology, and that is the haptics that I've discussed. And again, I would argue that the early career doctors and surgeons, certainly medical students, don't need to use their hands. Interns, that in middle group, probably don't use their hands, their watch. The second, third, fourth assist in Malawi aren't using their hands when they're in an operation. They're holding retractors and watching. So you don't necessarily need to use your hands to be able to perform or understand surgery. That's about knowledge acquisition in those early careers. Ultimately, when you're a resident, you need to use your hands. Manipulating tissue, you're only going to get in a cadaveric environment or in a surgical environment where you're with a good trainer who's patient with you and can talk you through the surgery. And that's a really important part of our jobs as surgeons, is to train the next generation. That's our legacy. And so that's where you acquire the haptics of tissue manipulation. There are simulations that are around, in particular orthopedics, for example, where they've done a randomized control trial comparing the ability to fix a bone in virtual reality versus in in simulated environments with sawbones, for example. And what they've shown in these kinds of scenarios is that you're 16 times more likely to remember something if you've experienced it in an immersive experience, and you're 4 times faster in acquiring skills if you've acquired them through 6 degrees of freedom. So these simulations were rudimentary, but they're starting to show much more finesse, and they're presenting themselves with what happens when you get it wrong, or if there's a complication during surgery. It's just that the combinations can be so vast. So newer simulations with generative AI are allowing us to bring in those scenarios that you described, in which you get suddenly hemorrhage, or the outcome isn't as you'd expect, or the anatomy isn't as you'd expect. I think, what I say to my cohort and my academic surgeons and surgeons in training is that I can think of nothing worse than putting a VR headset on my face when I operate. That's, as soon as you do that, that device becomes more than just an educational device. It's a medical device, and they're not licensed for that. I can tolerate loops because it gives me magnification and it gives me light, so it brings something important. But I have peripheral vision, and I need peripheral vision when I operate, not only in terms of how I manage my trainee and train them, but also when these complications occur. What happens when the anatomy isn't as you'd expect it to be? What happens when the equipment's not working? What happens if you have junior team members and scrub nurses that are not familiar with the techniques? What happens if the power goes out? It's that peripheral perception and the theatre of theatre, which is your finishing school, of managing all these challenges and complications. And I think that comes from experience. So you may get a bit of an insight in a virtual reality world of a hemorrhage that's in front of you, but in terms of how you actually manage it, you need to have had the numbers of training to see it. And then
No, I agree. I agree. I remember being, you and I both worked at the same hospital. I remember being at the Queen Vic, and somebody would come along, and the SHO would come down, and he would have to say do a blood or something like that, and 3 stabs and nothing's happening, because veins don't behave. They collapse, they squiggle, they move, and then the phlebotomist would come up, and the phlebotomist would do it in one go. Why? Because just what you've said, they've done it again and again and again. And I think you're right. I know that from a subconscious point of view, that if you train somebody for 30 days repetitively, the body, almost that muscle memory develops. And God willing, there's not going to be a situation where you have an arterial tear or something like that. But if it does happen, at least you're trained. Because one of the things that you and I were talking about briefly, I think it was about a week ago, was in Africa, you were telling me about the only experience that somebody had had was like on a pig's knuckle, doing some dissection or something like that.
Yeah, so I went out with my chief operating officer. Simulation and access to simulation resources when there is no availability of cadavers means that they have to use animal models. So in Askavim, in Yaoundé, Cameroon, we saw that where they were using pigs' intestines, and actually that's not too a million miles away from human anatomy. But an arthroplasty or endoscopic examination of the knee, and you're using a cow's knee, because that's as close as you're going to get in terms of anatomy. What's quite interesting with the virtual reality stuff, the work that we've been doing, is one of the applications we have is VR anatomy. And that's been quite empowering. Understanding complex three-dimensional anatomical perspectives when you don't have access to cadavers is quite a challenge. Certainly quite limited by books, although of course most of us have had that approach. But putting a VR headset on and watching a Malawian medical resident take the sphenoid out of the skull base and understand the relationship of the greater wing of the sphenoid and the lesser wing of the sphenoid for the supraorbital fissure and the optic nerve, and then the inferiorbital fissure. That appreciation happens when you can walk into the skull base in a VR simulation, and you're not. And they called it witchcraft, which is quite interesting. But they just weren't used to that. And what we're doing with VRIMS is we're simply donating that resource to 10 African countries in the next year, where we will give them our entire capability deck, and we'll see what happens. Give them a sophisticated technology to some of the poorest parts of Africa and see what happens. And I bet it's going to be something magic.
I think so too. I think my experience of Gambia was the hunger for education. I would say to some degree, when I saw the kids over there, for example, and we looked at some of their maths that they're doing, it was way beyond the maths that the kids are doing here, because education is a way out of poverty. Education really is. One thing I learned about Africa is I used to go there and give out medical aid, and we'd take a team out with us. The problem I soon learned with that is you create this sort of mentality of dependency, whereas education is a way out of poverty. Definitely works better. So in terms of the anatomy, one of the things that I've also noticed as well. So, for example, when I was training, we talk about the piriformis, that muscle in the buttock, and that anatomically it doesn't adhere to the normal standards. So you could have the sciatic nerve can go underneath it, can bifurcate it, or on top of it. We don't know why. Maybe it's a genetic abnormality. Can you incorporate some of those abnormalities to almost not to trick people, but just to show them that sometimes when you do that dissection, it's not going to normally follow not always follow the anatomical rules?
I think the technology is too early to have deviations from conventional anatomy. And it's also one of the problems with filming, and some our resources are on cadavers. And cadavers don't have pathology. So, going through an abdominal wall with a hernia is a very different operation to going through an abdominal wall without a hernia. And so the limitations of the approaches are that we don't have access to where that anatomy deviates. Now, when I go to Tanzania later this year, I'm going to be filming a workshop, so live surgery, with 5 or 6 patients with pathology, with hernias that are being repaired, create that immersive training resource, and then give that to the Tanzanians to use as a training resource. So it is possible to do certainly the immersive surgical experiences with pathology, but to be able to have the anatomy simulations that we use are standard anatomical perspectives rather than anatomy that deviates from norm.
And will it incorporate later on things like, for example, I remember when I was working in the Canadian wing at the Queen Vic, we had somebody come in and they'd had a pole go over, I think, and hit them in the head, and they needed a titanium plate, a cranial titanium plate on the frontal lobe. Will that, going down the line, can you see that sort of thing, reconstructive, incorporating artificial?
Well, we already do that. So I present quite a lot of work and very conventional and accepted techniques, and that have been around for 3-4 years now, called virtual surgical planning, where we will upload patient-specific, CT scans to be able to make decisions pre-operatively. We would plan and using, moving away from 3D printed models to now just a virtual environment where we can plan very precisely the surgery before it's done by using the patient's models, CT scans for bones. I can take the fibular bone, for example, and remold and refashion a new jaw by using 3D guided cutting guides that allow me to accurately take the bit of the jaw, the fibula that I want, and be able to simply slot that into the jaw at the top end from 3D printed guides that help me take out the cancer and then put the reconstructed part back in. So that's 3D printing and virtual surgical planning for patient-specific approaches, and some nice studies that have shown that not only gives better form and function, that's what surgery is all about for head and neck, returning form and function, but it also saves on operative time as well.
In terms of, and also for people who don't know, because if I didn't know, I'd be listening to you and thinking, hold on a second, you're taking someone's fibula out, how are they going to walk? Can you explain to the listeners, just imagine they've got no medical background, explain in a way that they can understand in terms of the fibula, in terms of what you're doing there?
Yeah, so you'd be surprised to hear that most of our patients are mobile or within a week of surgery. So you can actually mobilize. Of course, you won't be a high performing sports athlete doing triathlons. If we've taken your fibula away, it's going to compromise those kind of high functional requirements. But most of our patients aren't triathletes. They're elderly patients with cancer in the head and neck region. And so what we do is we take out the fibula, or we can take out a part of the hip, or even the scapular tip. Those are the 3 most common bony flaps that we use. The fibula is the go-to flap for jaw reconstruction. And we take out the fibula with an artery that's adjoining it. The peroneal artery is one of the 3 arteries that runs through the lower limb. So, of course, we'll make sure our patients have good 3-vessel runoff, they call it. You don't want to take off one artery when only one of them is working. You need 2 other arteries working. So we'll take out the leg bone with either some muscle or overlying skin, and the peroneal artery, which supplies all those components, re-anastomose the artery, the peroneal artery, to the vessels in the neck, and then reform the jaw for the fibula, and then use the skin if you need on the inside or the outside of the mouth. And then the patients are simply put into a a dressing. They sometimes have a skin graft if there's a lot of skin removed from the leg. They'll have a non-mobilization for a few days, but then we'll start to encourage them to mobilize. And you know, the part of the fibula that we take is very strategically taken. We don't take any fibula at least within 7 centimeters to the ankle joint, because we know that that affects ankle stability. We don't take a fibula proximal or near the knee by more than usually 5-6 centimeters, because that's where the peroneal artery joins the tibial artery. So it's all very kind of it's very prescriptive in terms of the surgical approach, very predictable, and those patients make a very good return to function post-operatively.
And can you plate the missing bit of the fib, or do you just leave it?
Don't need to really. You're just adding in another element that doesn't really add much. You can put in a plate over the span, but it's another foreign body, and that fibular bone doesn't make a massive contribution to the weight bearing and function of the lower limb.
Because I remember, I mean, for those who don't know as well, the Queen Victoria Hospital is very famous for the Guinea Pig Club. Second World War, they called them the guinea pigs, and they used to walk around town, and people respectful didn't stare at them or look at them, and they had a flap. For example, they would take a live part, not totally disconnected, a vascular supply connected. When it took, then they could use that to reconstruct a nose and etc. Is that still happening with live flap, or was it moved on from that?
So Mackinder pioneered those principles of pedicled flaps, they're called. So the pedicled flap remains attached at some point with the main artery running through the pedicle. So traditionally, when you take a skin flap up, which is a randomized random flap, the dimensions of that flap have to be predetermined. If it's too long and too narrow, the blood supply at the end is compromised and it can fail. And so those limitations for the head and neck, that it's often there isn't any tissue that you can borrow from anywhere else, because it has to span a long distance. And so what Mackinder found was that you can take a pedicled flap in which you leave the base of the skin attached to the trunk usually, and lift that up and use it and place it over the face, because it had a main artery running through it. So that's why you'd see patients walking around in East Grinstead when their nose was missing. You'd have a pedicle off their chest and the main artery and it attached. It would be attached for a period of time, 2-3 months. Once the pedicle attached end on the face revascularizes, gets a new blood supply, you can then detach it and put half back on the chest and half can stay on the face. So that's the pedicled flap concept. But what happened in the 80s, early to mid 80s, was this concept of free tissue transfer, where rather than just having it still attached to one part, you could actually just detach it completely and reattach it by doing what's called microsurgery. These are small vessels in the order of 1 millimeter, sometimes 2-3 millimeters, where you essentially stitch them together and reperfuse the vessels and therefore the tissue and the flap on the head and neck without having to keep it attached. And that's called free tissue transfer. And that's where the majority of us now will default adopt free tissue transfer, because the functional outcomes are much better.
And the vascular supply is okay with that? There's a decent vascular supply.
So if I take the vascular supply from the lower limb, for example, the peroneal artery, I can take that one artery of 3 and not compromise the lower limb. And then when I take the facial, often with head and neck cancer, you are removing lymph nodes, and in that process, you're exposing all the vessels of the neck. So I can detach the facial artery, is the most common one, or the superior thyroid, and reattach it to the peroneal artery and reperfuse my flap.
Well, it's really come on. I mean, I remember the days of hunting around the bed for the leeches when we'd had thumbs that had, people didn't realize it was like Middle Ages, but thumbs came off, and we'd stick the leech on the end of the thumb, and we'd go in, and the patient, you had to go and check it, and you go in, there it was, the kind of, little old me, lowly auxiliary nurse, and there was this. My job was to go and make sure there was no leeches on somebody else's body parts. It was.
I've come across it twice in my career. We use it for digit injury, where the vessels can be very small, and what they do is suck out that blood and encourage further flow because often there's a venous insufficiency. That's the issue with and indications for using leeches. I've come across it a couple of times, but microvascular surgery has success rates of in the high 90s now, so it's all very predictable.
And PRP, platelet-rich plasma, innovation in MaxFax, I hear about that more as well now in terms of what's going on.
Jury's still out on that, I think. If you look at the randomized controlled trials on PRP, They are, there's an industry perspective on pushing this. It's very difficult to prove whether PRP per se, and the example I'll give is the implant dentistry. It acts as a tissue glue essentially, and can be used for facilitating flap, sticking down onto bone grafts and reducing dehiscence. But I think it's really difficult to prove in its own right that it has a significant effect on outcomes, because the trials will be quite difficult to design.
And going back, this is another question that people have asked me to ask you, because it's something I come across quite a lot, which is that we refer to them as four eighths. You refer to them as four eighths. The four wisdom teeth in extraction. Do you think that extraction is to do with development of humanity in terms of the way we masticate, we eat food, and therefore the jaw expansion of the maxillomandible, or do you think that is just something we've done routinely and we just do it?
So there's a kind of there's a anthropological perspective on that theory, and the theory is that as the Western diet has become more and more refined over the centuries and thousands of years, what that's meant is that we are less likely to grind our teeth down. So the prehistoric men, a typical diet would have been lots of grinding of vegetables, and so as the change in diet has happened, you're less likely to grind your teeth down. Now, most teeth have a bulbous crown with a point of contact that's midway down the crown. If you start to grind your teeth down, you then grind it below the contact, the teeth will move forwards, creating space at the back for your wisdom teeth to come through. But what's happened with the ultra refined diet is that we're not grinding our teeth down and maintaining that contact, and therefore maintaining the position of the teeth, and there's nowhere for the wisdom teeth to come through. So that's why you get impaction of third molars, because there's been a change in diet over the centuries.
That makes sense. And also, I'd come across a theory which I quite like from a nutritional point of view, which is that also because the diet, it's softer. It generally, I would say, people who have a good diet, they have a compact protein, compact carbohydrates, good quality, and that the human brain itself is expanding, developing, and because of that, the frontal is having to compress, and the arch is becoming higher. I'd heard that too in terms of there's, I think you and I talked about it, the book called Breathe. I think you've read it, haven't you? It's so in terms of more snoring and things like that, the whole kind of respiratory system is affected.
Yeah.
So that was quite interesting. So I want to talk about your app because I'm quite excited about that.
Yeah.
So you're developing this, I've got it down here, augmented reality app I've written down. How does it work? Can it help regular people?
So we've talked about the virtual reality resources that we've created. We've also got an augmented reality app that is used to help facilitate surgical decision making. It's an app. So as a facial surgeon, I manage each of the facial subunits, they're called, differently. And that's all about tissue laxity. So for example, the nasal tip is adherent to the nasal cartilages. So there's no real movement of the tissue around there. So if you remove a cancer from the tip of the nose, your approaches to reconstruct that will be different to the approaches to reconstruct the same cancer in size to the side of the cheek, because the side of the cheek is very flexible. You can simply just close that primarily, or you can borrow tissue called a flap from surrounding structures. The nasal tip has to be managed with a skin graft. So traditionally, and certainly from my training, when we looked at how to manage the cancers of the various subunits of the face, you'd have the book of the subunit concept behind the patient. You'd flick to the chapter where the cancer was on the cheek. You'd look at the various geometric approaches to the types of flaps, bilobe, a rhomboid, that's all very geometric approaches. And you make a decision which subunit it was and which kind of flap you're going to adopt. Draw that out, numb the patient up, and then remove the cancer and rotate your flap. Well, imagine having a mobile phone in which you simply point it at the patient's face, and it can overlay the subunits, but also help surgeons make decisions about how to manage each of the subunits and give an overlay of the geometric options you have for each subunit. So the rationale and the reason for that is it's a technology that's in everybody's pocket. Your phone does this every day, hundreds of times. If you are obsessed with your mobile phone. Every time you put your phone up, the face recognition is triggered by certain points on your face. So that same technology in your pocket is used to create a mask on the face that can overlay the subunits and break the face down. You click on the subunit that's involved and it gives you the geometric approaches, and then therefore gives the surgeon options as well. You attach something like a dermoscope, which is a small little light that can shine into cancers and take a photograph. Now you've got an opportunity for artificial intelligence approaches in diagnosis, helping surgeons make a decision on the margins to take, but also then on the reconstructive options for the various subunits. So it's an example of where you can use augmented reality to help in diagnostics using AI, but also surgical decision making using augmented reality.
Can you incorporate thermal imaging? Because again, there's a lot of thermal imaging being shown. I mean, there's very few doctors in America being able to actually read them. So there's people doing thermal imaging in the UK. They send them to America. Apparently, it's picking up breast cancer way before, mammograms or anything like that often, and it's also not invasive too.
Yeah, you'd probably need something a bit more sophisticated than a mobile phone with some kind of a device that you attach to be able to get thermal imaging. You can use LiDAR, which gives the three-dimensional perspectives, and that's a technology that's found in more and more mobile phones. Apple were the first to do that. So, but with thermal imaging, you probably would have to have, unless you can get the developments into the mobile phone to be able to pick that kind of an image up, you'd need to have to add something like I've said, a dermoscope, where you can have that specific component added.
And how does it work in terms of, obviously because these sets are quite expensive, there's sophisticated bit of kit. So let's say I'm for example, you and I talked about how this could be transferred into chiropractic colleges, especially in America, big business. But it means that, because when we did cadaver studies and that, you've got the ethics committee, there's so much involved. I mean, the first thing I can see about that is this isn't a real person. So that there's the ethics side of it is protected to that extent. But I would imagine you could change it for chiropractic or orthopedic or even midwifery. I suppose you could even go as far as that.
So I think there are three reasons why this technology hasn't taken off, not on a grand scale. And the three big players in the hardware are Meta, HTC, and Pico. The three reasons why the technology hasn't taken off is because of content. A 6DoF simulation digitally created is really expensive. Basic life support we've got on that cost us £50,000 to build. A fire safety mandatory training, another £50,000, prohibitively expensive. So content is one. The second is the hardware solution, and then the final one is the manpower to be able to scale this up. And that's what we managed to do with RIMS. We developed a huge resource of surgical content for every surgical specialty with 230 simulations, from obs and gynae, general surgery, orthopedics, trauma, reconstructive surgery, even transplant, and more recently damage control, so emergency frontline surgery. The hardware solutions, we've had to just unpick that and try to understand what gives us the best form factor, the best user interaction, and we've got a couple of solutions. But the final reason is the manpower to be able to scale this out. We created the Surgical Society, Vroom Surgical Society, only 6 months ago, and in the last 4 months they've run 80 training events, and now in every medical school in the UK. So that's how we've managed to scale up as a medtech startup. But in terms of applications in other specialties, it's quite easy for me to be able to extrapolate, because there isn't any one solution I've realized that would allow for wide scale adoption of this technology. You have to give what we call in rooms the total XR solution. Beyond the technology, you need to have a process in place to onboard, a technical support that's there Monday to Friday, an ability to come in at least on a quarterly to be able to manage new updates on apps, and then you find that some of the simulations don't work. All with then a background of deep dive sessions for staff so that they can understand the full capabilities. So that's kind of the support we offer in terms of the technical aspects, and then applying that to your specialty. We can film in 360 with a single 360 camera, but that's limited by looking around in different perspectives, and actually you're a very physical specialty and getting those different perspectives, and nobody's going to stand still when they're watching you perform. They're going to be moving around constantly. We create these additional overlays called Virtual Studio Overlay. So we can create a whole library in a day where we just bring patients in with a variety of pathologies if they're willing to consent for that. Or we use mannequins, or we use actors where you can simulate that on a variety of techniques that are filmed with overlays. We would then We'll upload those either onto the cloud or onto the device. But this is where it starts to get really interesting, because what we can do with those simulations is that we can use something called synchronized VR. This is the one thing that's really, really getting a lot of attention. If you imagine I have a room of 20 doctors, surgeons watching me perform a surgery, all in synchrony, where I can then see what individual is watching, but also articulate specific pearls of knowledge that I've acquired through decades of training to all those trainers and say, look at the view to the left for this particular emphasis, look at the view to the right for this particular part of the procedure, look at how I'm holding the tissue, look at how I'm holding the limb, look at my body posture and the patient's body posture. That articulation in synchronization has real value and can be applied in those simulations that we've created. And then the final two, we've talked about the VR anatomy, picking apart the anatomy and understanding the anatomical perspectives with a virtual dissection. We had a teaching session last weekend in which we had a student from Birmingham, a student from Leicester, Liverpool, one in Mexico, and one in London, all with me putting a VR headset in, and I'm in sunny Brighton on the south coast, and they're with me in this virtual room, and I'm demonstrating how I would dissect the facial nerve for a parotidectomy, and then I can hand over to them to actually do the dissection themselves as well. So it gets around the problems of barriers of geographical limitations, and that's why we're creating these hubs in Africa. If you imagine you've got a surgeon in Manchester who has an interest in abdominal wall reconstruction and wants to run a training session with surgeons throughout Africa, they put a headset on and they're in the room with him learning how to do that. But the final bit of technology that brings it all together is something called interactive video. So those video experiences that I've described are immersive, but they're passive experiences that we make interactive by putting them through an interactive software. What that will enable then for you to do is that you can then start to create assessment tools by putting questions in there, multi-choice questions in there, by adding hotspots that are triggered when they pass go. You can add in additional videos or additional sound bites or PDFs of algorithms into that simulation, and it will take me 15 minutes to train you to do that. So now what you're able to do with that simple video with the overlays is not only synchronize that experience, but actually change the narrative of the videos depending on the level of training. So a very junior clinician in training may need different requirements to a very senior clinician in training. But imagine collecting the eye tracking and watching what everybody's watching, recording that, feeding that into an AI approach, and then having something called adaptive learning, so that the simulation simply changes depending on the level of training.
That's incredible. I mean, the first thing I thought about when you said that was, first of all, the crowding. There's nobody trying to look over your shoulder, trying to get the best view, maybe getting the right angle, a left angle. And then the other thing I thought of straight away, which is I thought of a military application, which is trauma, because a lot of people are going to places like, unfortunately, Johannesburg, because in a week in Johannesburg, they will often get more experience in seeing knife crime, gun crime, for surgical purposes. And straight away when you said that, I thought this is incredible implications for trauma.
I think the feedback that we've had from more than 1,000 medical students that have experienced our workshops in the last 3 months alone is that it gives them the best seat in the house. And these are their words, not mine. It removes and eliminates the traditional hierarchical approach and constraints in a theatre environment, because we're not constrained by that hierarchy. We get to see the operations with surgeons describing the procedures. And also we are exposed to specialties we never normally would get exposure to, like transplant surgery or cardiac surgery or reconstructive surgery. How do you know you want to be a cardiac surgeon if you've never seen it? So you're not constrained by what is traditionally most surgical approaches in the undergraduate curriculum is general surgery, because what they want you to do is understand general surgical perspectives for GPs. Ultimately, those junior doctors are in general surgical firms, but the medical students saying we don't want to do general surgery. We want to see plastic surgery. We want to see transplant surgery, and your resource is giving us that exposure that we wouldn't normally get.
It's great because it really gets the brightest and the best who are passionate, because I believe that if you're going to really be in healthcare, one, you've got to have a passion for it. But I remember, do you remember Project 2000? I don't know if you remember Project 2000. The problem for those that are listening to understand, Project 2000 was basically a classroom learning, which they said they could take nurses and essentially you had to have a certain qualification, academia, put you in a classroom. But the problem was, and I saw this, was that the way I learned was on the ward. So I had to do something like 1,000 thermometers, had to do BPs, and you were ticked off and ticked off and ticked off. It was like the old-fashioned way of doing it. And Project 2000, a nurse would arrive in the ward, never been on a ward. It's all been simulated in sort of books and things, and then realized that they had to wipe someone's bottom, or that a toilet isn't a lovely, great big manual handling environment. And then they would leave nursing. And so when you're saying that, I think this is great, because straight away it can ignite the passion for a particular specialty that somebody wants to go into.
I think, how do you know you want to be a nurse unless you are doing the things that a nurse typically does on a day-to-day shift? You need to be out there talking to people. I think we've got this wonderful additional resource called Virtual Humans, and again, we can train people within minutes to be able to create your own avatar and virtual human, which can be a patient. What's really quite interesting about the use of VR for virtual humans is that these are ultra realistic conversations that you're having with, with AI approaches. ChatGPT 4 Omni in the latest version gives you an almost near realistic and very short latency reactions of these virtual humans. So what that gives us then is an opportunity for us to put students through experiences they would never normally be exposed to, like breaking bad news, managing an ectopic pregnancy, managing a depressed patient, and then seeing what happens when they're having these really challenging conversations. And don't for 1 minute think that doctors are brilliant at giving patients bad news. Surgeons are terrible at telling patients that they're not going to survive and that they're going to die. But watching medical students in those challenging experiences is a real kind of penny drop moment as to what opportunities this technology offers in terms of those soft skills and developing communication skills.
Yeah, I think it's really exciting. It's almost Star Trek stuff, It's growing up with that environment. So listen, I could talk to you for hours and hours and hours and hours and hours, because you and I we're very passionate about this, I can see. So we have this couple of traditions. First of all, how can people reach you if they need to get a hold of a company, if they want to get a demonstration?
Yeah, sure. info@vrims.net. That's VRIMS, Virtual Reality in Medicine and Surgery.net is the email. Drop us a line if you're interested in seeing what our Total XR solution is and how we can help you adopt this technology into your clinical practice and educational background.
Okay, and then we have a tradition here, and I know we're going to have to bleed this out of you. I know you don't like blood, but I do want a favorite quote.
Yeah, I do have a favorite quote. So I believe you have to be willing to be misunderstood if you're going to innovate. And that's certainly the experience that I've had. And this is from Jeff Bezos, who is about the kind of the pinnacle of innovation and modern medtech entrepreneurship. But I think what it demonstrates to you is that you'll come across many challenges in your journey when you have a good idea, but you just have to stick to your guns and just keep going, and then everybody will eventually get it, we hope.
Yeah, and don't do it if you want to be liked, right? I mean, I have very strong opinions about health. I think it's chemical, physical, emotional, and over the years we're moving towards functional medicine. I've taken a lot of flack over the years over that. They consider you kind of a bit kind of hippie and whatever, but I believe still in the goodness of man, really. So, Jag, thank you very, very much. I can't wait to release this episode. I have many, many guests on, but I have to be honest, this has definitely been one of my my favorites. I've really been. I think my wife thinks I'm a kid in a sweet shop, to be honest. When I said I was going to get you on, and also especially because we have the good old Queen Vic as our background.
Thank you very much for the invitation.
Yeah, absolute pleasure. So but I'm sure we'll catch up soon.
Okay, take care. Have a good one.
Bye. Bye.